Hello, and welcome to the No Bad Questions podcast, where I try to learn in a conversational manner by sitting down with people who have interesting careers, important lessons to tell, or inspiring stories. I hope that you learn something too. If you want to support the podcast, please follow or subscribe on your platform of choice. You can also like or comment to boost the algorithms or share out to your network to make sure it gets more views. But ultimately, and what I hope you choose to do, is listen to the very end. With that, we'll start today's podcast. Hello, everyone, and welcome to this week's episode of the No Bad Questions podcast. My guest today is Janis Powers. She is the founder and CEO of KnowThyself, a digital health platform that helps people avoid healthcare they don't need or want. Janis has been involved in the healthcare industry since the mid-1990s. She's been a strategy consultant for most of her career, analyzing healthcare data for almost 3 decades, which has given her deep insights into how the data is collected, who gets access to it, and how it is used. In 2018, Janis published her best-selling book, Healthcare: Meet the American Dream. The book is a proposal to eliminate traditional healthcare insurance by predicting health outcomes. It is the genesis for KnowThyself. Janis majored in architecture at Yale and earned both an MBA and a Master of Architecture from the University of Michigan. She was born and raised in New York, but has spent over half her life in Texas, where she currently lives in Austin without her 2 fantastic college-aged children. Janis, thank you for being here with me.
Thank you for having me.
So at this point, I think when people think of big data, they think of either Edward Snowden and the NSA, or they think of Facebook and Meta and YouTube and all the data that they collect about all of us, and they probably don't think a lot about healthcare big data. So what is big data in the healthcare context?
Well, that's a big question. I think you have to ask yourself, what is healthcare data? Mm-hmm. So traditionally, like in the old consulting world, you'd go to a provider or an insurer and get their data, mm-hmm. what they house on their systems. And I worked for providers or doctors in hospitals. And so it was always like what was in their electronic medical records, what was in, what patient data were they holding sort of locally?
Okay.
Now that we understand that there are many factors that impact health outcomes, we've realized that there are so-called social determinants of health or external mm-hmm. determinants of health. And so everything in your life impacts your health. So, mm-hmm. If you're sitting all day long and Google knows that because you're, searching the internet, that's healthcare data. I mean, what do you do? Like where you drive, Google will, if you've got your locator on and you have your phone with you, Google knows where you're going, where you literally are, the air quality, like that's healthcare data. There's just so much of it that I don't think anyone really knows what to do with all of it. And I think that it's a challenge to think that a tech company, I think it's arrogant to think that a tech company, just because they have folks who understand their own data, will understand how to properly analyze healthcare data.
I hadn't even thought coming into today's conversation about the consideration of location data as healthcare data or air quality. So that's really a fascinating point about the sprawl of healthcare data today when we consider all these other factors that go into your health. So that's a really interesting and great point. And it actually makes my next question all the more complicated. So forgive me for that. But who owns your healthcare data then, right? If it's all these different puzzle pieces, both the medical chart and your location and who owns it? Do you own it? Does the company own it? Who owns that data?
Well, no one knows. We don't know. So there are no laws around that. And I think we are starting to creep into that area of trying to understand like who has ownership of this stuff. I mean, de facto, you and I should own our own healthcare data.
Mm-hmm.
I mean, it's ours. What is disturbing to me, and I think is becoming more and more of a concern for more people when they realize who is using their data and who is accessing it, is that other people are making money off of our data. Mm-hmm. So we all understand how Facebook, Meta, but Facebook, the product, and Instagram, the products, make money off of our data. And that's a trade-off that we've made. And I don't think people really understood it until late, and maybe they still don't, and they don't, or they don't care. They see value out of it. But we give them all sorts of information. We're on there, looking at stuff, posting things, and they call all of that their own way. They have figured out how to monetize that information and resell it. And, obviously with advertising, they can make money there. So that's the social media world. But technology companies and healthcare companies are also making money off of our data. And if you are a company that installs electronic medical records like Epic or any of those companies, obviously they have a product. So, their product serves to house and help providers analyze data. But then they're also sort of making money because if you're an electronic medical record, a lot of the value, and you understand this probably better than a lot of people, a lot of the value that these EMR companies or EHR, electronic health record companies, bring is that they'll help with reimbursement. So they'll go through and say, okay, here's how the billing codes work. So doctor, make sure you ask these questions, or nurse, make sure this is in the chart, because if it is, then you'll be able to bill more. And, some of these companies will then, make money off the fact that, you're being charged more as the patient, even if your insurer is paying for it. Somehow it's just not right. And then there are other ways that are starting to happen where I have seen some tech companies that are starting up now, and they're trying to collect your health information from disparate sources and consolidate it and then resell it to providers. And the pitch is, well, we're going to get all of Janis's health data because she went to this Ascension hospital, which has one set of, health systems. And then she went over here to this other health system. So those systems don't talk. So we're going to collect data from those two systems, consolidate them, and give Janis, try and create a record of Janis's, and then resell it to back to those two companies or to a third party. And that's my data, right? That's just ethically wacko.
Well, let me argue the other side of that just for a moment. If I'm going to several different providers that don't talk to each other, because I don't know, they've got competitive rivalry or whatever, from my perspective, don't I want them to be able to see the shared chart so that they can coordinate care and things like that? Couldn't that be a good thing?
Yeah, well, that's the argument. Right? Mm-hmm. That, shouldn't all this data be in one place so that people, your physician has a full record of everything that's gone on. But my perspective, and this is a lot of, what goes into KnowThyself and what our company does is, what information do you really need? Right? Because a lot of what's in the electronic medical record is garbage. Mm-hmm. Do I really need to know that I got a pre-authorization from this thing, and then I had this scan that was clear, and then, because it was a BS scan that, a doctor was like, oh, we might as well do that because that's the protocol, and right. I didn't really need the scan, but it's in the record, and then all that, nonsense data is in the record, and all of it gets analyzed later because we have this wealth of information, but so much of it is not useful. Mm-hmm. And when it really comes down to it, and I'm not a physician, right? But when you talk about problem solving, I am very good at that. And, you want to separate the knowns from the unknowns. When you have a complex problem, you take everything that you know out and, you want to focus on what the real problem is.
Right.
And I don't think that has happened in the healthcare data world properly for most people yet. So this idea that I'm going to get my data from all these different places, that's problematic because the data set is junk. But then, as we talked about initially, you're still missing all of this other important stuff about your lifestyle and everything else. And that's not in there. So, you can have all the health data in the world, but if I go to Walgreens and buy an over-the-counter medication and it's not in my record, and then you give me a drug and I have a reaction to it because I didn't tell you that I was taking this thing, what was the point?
Right. And the other thing is that even if all of the data in the medical record was useful, and I'm not disputing your point that some of it is not useful to a clinician, are they reading it? Are they actually looking at it? I can tell you from like my children's experience. My children are younger than yours from the sounds of it. And, we've gone to, one of them needs care and goes to a nationally renowned children's hospital. And I swear to God, they don't read the chart. So, I mean, every conversation, it's like you're having the first conversation over and over again. And I have to imagine there's probably some useful nuggets in there, given that I have to keep telling them, each time we visit. So, even this sort of pipe dream of a unified health record where everything that could be impacting your health is there, then maybe that just becomes data overload. And that's probably not particularly useful either. And I think then we get into one of the major downsides that I see of a unified record, which is hackability. Spent a long time on episode 2 talking with the cyber expert there about, your data getting hacked. And we see these stories of ransomware attacks on hospitals increasing and so forth. So I don't want to go down a cyber security rabbit hole, but I mean, do you feel that is one of the major risks or limitations of that unification of health data?
Well, obviously it is. And healthcare is the most hacked industry. People just don't realize it. But I think it's an inevitability that just like everything is electronic now. So I think there was a fear before that, it was the holy grail to get your healthcare data because it wasn't just private information about you. It was your family members, your financial information. You could steal your identity. That was the real fear in accessing health data, that it really enabled people to do identity theft because you have so much information about someone as opposed to someone's fear of finding out that you're HIV positive or, any truly private information. And so of course it's a fear and a concern, but I think that, that's something that is just part of who we are as a society.
Right.
I mean, look at how war is done now, right? We're like, it's all like cyber stuff. So it's everywhere.
That's
I
fair.
really think that ultimately our electronic data, and I wrote about this in my book, should be on a microchip on our body, right? I mean, what is this common denominator in everything is you and me, right? So when I do go to Walgreens and get that prescription, shouldn't that be part of the record? And every time I go somewhere and have something done, that's mine, and I should be able to, house it with myself. I think that's a scary concept too. But if you can dream it up, someone's doing it.
I've read a little bit about people who are doing biohacking and are embracing that type of technology. I have to admit, I probably would not be an early adopter on that, but I love the idea of we all carry around a credit card,
right?
Why isn't my healthcare chart just on a credit card and I swipe it and I don't mean a literal credit card, but on a credit card size data transfer device, that here's my record. And to your point, if it's a health related transaction, I swipe my payment or whatever, because that makes it really portable. It
right.
makes
But who
it,
pays for that?
yeah.
I mean,
and we don't seem to have that.
It doesn't exist because there's no revenue model for it. I mean,
Well,
this is the joy of being in a healthcare startup or any sort of, entrepreneurial endeavor is, you have to do that trade-off of, if there's no market for something, then it's hard to convince investors to invest in it because there's no market, because they're like, well, who's going to buy that? But then if you're going to create something that's already out there and there's already a market for it, then, you do these little innovations because it's like, oh, well, if they like that, then they'll like this. And I can see why someone would buy that. But to come out and say, hey, let's spend all this money and like get all this information, on your phone. And then you person have to pay for that. And then not only is that the challenge, and I have obviously considered this because I wrote about it in my book, the real issue is getting the providers then to be able to access it.
Right.
Right. So, we can make it as amazing and small and curate the information so that's the most valuable stuff. But if I go to my doctor and they don't have the ability to connect with that and upload that data and use it, then it is useless. Mm. So until the providers want to be able to connect to it, then we will not have that. But we'll make little baby steps, make progress, because at some point that's really where the data should be.
Yeah. You're certainly making me think about like where, you can't turn back time, but where did we go wrong then? Years ago, the government was incentivizing healthcare providers to adopt electronic records. And was that, should we have pointed our dollars at incentivizing, like we're talking about, some level of portability, or maybe the technology wasn't there yet for that level of portability, and now it is. And so it's certainly making me think about that. But let's talk monetization a little bit. You mentioned earlier that there's data companies sort of taking healthcare data and then selling it back to providers. We just talked about there's not a great revenue model to, get people to be having the tools to have their data be portable, and then to get the provider to access that data. There's layers of monetization that either is or is not happening. So can you talk a little bit more, or elaborate a little bit more on organizations that are taking what I think we're both in agreement is really should be our data, and they're pulling it out of these systems, and they're figuring out ways to make money on that in healthcare? How is that happening? Where is that happening, et cetera?
Yeah, I mean, this is the big old irony, right? Is that if you talk about health inequities, and it's such a loaded term, the people whose healthcare data you as a provider want the most are the people who are the sickest, because they're the ones who are going to be accessing care. So the sickest people, are either older and they're on Medicare. So we'll just bilk the Medicare system because that thing is just like, I don't even want to go there, although maybe we will. So they're either older, or generally speaking, they're going to be low income, which is the Medicaid system. Okay. So, those people are generally, they're going to skew to the less healthy, and they can't, low income, they can't pay for it.
Right.
They can't pay to buy their own data, hold it, house it, and then, sell it back.
Right.
And so the buyer of the data is going to be in, a value-based contract. They're going to be in an arrangement. For your listeners, I'm sure, it is a complex topic that I have a whole chapter in my book about value-based care and how just difficult it is to monetize. But the concept is that, hey, doctors, instead of you just getting paid to order tests and drugs and do procedures, let's have a comprehensive, holistic view on the outcome for the patient, and say, we're not going to reward you for this, just fee for service, continuous like billing us stuff. We want to reward you for an outcome. So we're going to create this contract and reward you on value. And so if the patient has the however you're going to measure that positive outcome, if they achieve that, then you get rewarded, provider. So that provider then is incented to buy all of that data and house it and own it, so that they can really do a good job managing the complex issues of the patient. Because the more complex the issue, the more expensive it is, which means there's more money to be made off of it.
Right.
So this is a really tough problem, and why people just ultimately think, oh, this should just be public health, because the government should just run it, because it's just not fair. And that's always been an issue, that, the folks who are the sickest are the most expensive. And, are they that way because they're lazy? Are they that way because they have congenital things they were born with? Are they that way because of income inequality? Or is it racism? I mean, there are so many explanations and reasons why people are like they are. But at the end of it, for the folks who are going to require a lot of money to be spent, they can't afford to be in this equation we're talking about.
That makes sense. And I don't know if there's even anything to be done about that, right? It's sort of like you said about the cyber. It's the state of society. It's the world we live in. Your data isn't your data. There will be people who can create financial incentives around it. Mm-hmm. They're going to sell it, and you probably don't have the money to intervene in that. Any given American, any given human, because I'm sure this is happening in other countries as well, but you and I operate here in the United States. But,
yeah.
And so
I would say that all is not lost, though. I mean, we talk about this stuff doom and gloom, but here you and I aren't in a hospital right now.
Right.
We're healthy. You spend the majority of your life not in a hospital. So, there's a great statistic, and I don't know how valid it is now after, COVID, but don't quote me on it, but I'm now going to try and quote it, but it's from the Peterson Foundation. And they do great research. The Peterson Foundation and the Kaiser Family Foundation does great research as well about cost data. And, there's a statistic about how really polarized the spending is, that there are really just, 5% of people who are responsible for 50% of healthcare costs.
I've heard something similar to that.
Yeah. And so it's really, so when you think about this problem, and again, going back to the knowns and unknowns, for the vast majority of us, and I'm not even talking about people who are low income or older, everybody, for the vast majority of the 335 million people in America, we're not dealing with this complex health issue. And, all these years I've been working in the industry, there's all this focus legitimately on where the money's being spent, right? As a healthcare consultant, there's okay, let's go figure that out and focus our energy on that. But as an entrepreneur and as someone who's thinking, well, how can I fix this? What can I do? I'm more concerned about what the trickle down is for you and me, and what our experience is, and why we have to put up with all the junk that is going on to treat the complex issues, and how distracted people are, meaning providers, from dealing with you and me, to your point about your children. I mean, I have been to, I have two kids, two college age kids, and they're without me, meaning they're awesome people. And I have gone to the same doctor for, 25 years. I don't know if he remembers that I have photos, he helped me through the whole process and birthed my children, It's they're so overwhelmed with stuff. And I have empathy. It also makes me angry, but at the end of it, this is on you and me, right? You and I, as health consumers, I don't even call us patients anymore. it's our job now to get on top of our health issues because the system won't. And that's really the genesis for writing my book and for Know Thyself, and why it's called Know Thyself. It's like, you've got to advocate for yourself and get an understanding of how the healthcare system works, because if you don't, then, you're rolling the dice. And that has nothing to do with the fact that doctors don't care. Of course they care. I mean, who wants to do all that in medical school? They care. It's just such a difficult field to be in right now. And we have to help ourselves. And by helping ourselves, I think we're going to help the physician community. And then that's just better for everybody.
I think one of the key, if anybody's listening and trying to learn more tips on should you ever need care, how to interact with the healthcare system, you just said it, which is you have to make sure you're advocating for yourself. If you're going in for a surgery, something where you're going to be unconscious, you need to bring an advocate with you, family member or somebody that you trust who's going to advocate on your behalf. Healthcare professionals, physicians, nurses, they're in most institutions in the modern age, and probably compounded by staff shortfalls with COVID, are so busy that despite all best intentions, things happen. And things could be as innocuous as they didn't read the chart, so they don't remember what they talked with you about last visit, like I was joking about earlier. Or it could be as not innocuous as the situation out of Vanderbilt, I think it was last year, where there was a patient death as a result of a incorrect medication given. It was very publicized because the nurse had criminal charges. But I'm not here to debate the criminal charges. My point is, somebody helping advocate for you should you interact with the system is, I think, one of the key elements of interacting with the modern healthcare system. And when you can, that's going to be you advocating for you. But in some circumstances, you need to have that proxy or whatever with you. And so that, I think, brings us to a level of the conversation around consumerism and that self-advocacy requires you to do more, track more, keep a file, whatever, of what you got going on. So talk a little bit about Know Thyself then. What is your mission statement? What are you trying to achieve? I mean, I had it in your intro, but I mean, can you elaborate on that? Tell people what it is or what your vision is for helping individuals advocate for themselves, be a better healthcare consumer. And as you said, or as your mission statement is, to avoid unnecessary care. Talk a little bit about your organization.
Yeah, well, thank you. And there's so many things I wanted to pick up on what you've said. And if I don't get to it in explaining Know Thyself, I want to talk a lot about healthcare consumerism. But Know Thyself is a digital health platform. We're consumer facing, meaning we're going to, go to market selling to consumers. Investors hate that because it's expensive to sell, but we are people advocates. Mm-hmm. And the pitch is that we help people avoid healthcare they don't need or want. But what we really do is make sure that you're getting the healthcare that's right for you. To the point of so much healthcare being done that's not necessary. We are initially going to market targeting women because women access the healthcare system more than men. Women in their, between 30 and 50 spend, over $1,000 a year on healthcare they don't need. There's over $120 billion spent on unnecessary healthcare in America every year on things that are just not needed. But you don't know that as a patient, right? The classic example is, and I'll give you an example for an experience I had, and these are the things that we are trying to help people who use Know Thyself avoid. I'm at a certain age and the doctor's like, okay, you need to go, get this bone density scan. It's called a DEXA scan. And I haven't had health insurance for 4 years, so I pay for everything. And I'm like, okay, why do I need that? And they're like, well, we want to, we want to start tracking you for osteoporosis. And I'm like, okay, well, why? Like, Well, I don't care because I already know that as you age, and this is men and women, you need to incorporate weight training into your workout routine because that helps with your bones.
Protect your bone density. Yep.
Yes. And, you should take calcium supplements, and there's elements of your diet that, you need to modify or correct to ensure that you have good bone health. Other than that, there are some kind of radical drugs that you can take if you have a history of osteoporosis in your family, which I don't. And I'm not taking those drugs. So I'm like, I don't care what my bone density is. What is the point of that test? And so I was like, I'm not doing it. Just not doing it. I'm not paying for it. I'm not exposing myself to the radiation. I'm not taking time off from work to do this and then deal with God knows another bill that will probably show up because, who knows, no one knows what anything costs anymore. So I'm not doing it. And that's that. I get to say no. I mean, the thing about being a patient or a healthcare consumer, that's what I call patients now, is you don't have to do anything that your doctor says. You can get up and walk out of the office. And I don't think that we realize that. And I think that doctors hate that concept because, they want to help us. But in the end, if it's just a cha-ching, and it's like, go do this, because then at some point we people have to say, okay, what do I really need? So that is what Know Thyself is all about. So how our platform works, it's totally private. We're not connected to your insurance company. It's a subscription service. You do a survey that we've developed. I don't even call it a health risk assessment because it's not. We're collecting information about you. And this gets back to what do I really need? And so much of what we collect is, what is your job? What do you do all day? What do you do in your free time? Did you play sports in high school? Did you do them in college? If so, which ones? Really get into the elements of your life that are going to impact your health outcomes. And we take this information and combine it with decades of research. And we say, hey, David, we think in the next 3 to 5 years, these are the interactions you're going to have with the healthcare system. And these are the, potential health outcomes that you might have. So we're making these sort of predictions, but we're not doing it in a 23andMe perspective, where it's like, we think you have a 68.4% chance of, getting gallbladder disease. I mean, what a useless piece of information, right? I mean, our view is, because of your diet and your family history, we think this could happen. So just be on the lookout. We're not diagnosing anything, but what we do, which is awesome, is we say, if this happens to you, here are the ways that it gets treated. So before you go to the doctor's office. And it's sort of like a companion. Know Thyself is like a companion that helps people before anything happens. And it's not just like gallbladder issues. It's all the preventive stuff that's going to happen in your life. So for women, because we go to the doctor all the time, they just love to test the hell out of us. It's like, do you really need a DEXA scan? And we'll say, based on your background, we're never going to say no, but we're going to say, yes, you should have this, or maybe. And, the idea is, okay, if it's a maybe, then we're like, you should talk to your doctor about the pros and cons of this. And we explain, what it is. So that overall is the goal. And by giving people these clinical protocols, it lets them see not only what could happen, but options. So if your doctor's saying, oh, well, you need to go get this MRI, then you can look and be like, okay, I actually really do need that MRI because, they need to see where to do the surgery and, what the problem is. And they need to get a better look at it before they cut me open. So yeah, I think I should go have that MRI. Or for back problems, this is classic. Oh, go get an MRI. It's like, okay, well, for what? I mean, if I really just need to not sit all day and maybe like do some yoga and potentially lose some weight,
Or lose some weight.
Right? Like, is it the MRI the answer? Because are we just trying to figure out what the problem is? We know what the problem is. You're sitting around all day, right?
Right.
Your back's going to get hurt. Like, so we're just trying to get people to interact with the healthcare system in a way that doesn't bleed them. And, you know, you mentioned I majored in architecture. I have a degree in architecture. Louis Sullivan said it best: less is more, you know. The less you interact with the system, the better, as far as I'm concerned.
Well, and I think there's elements to that. When I think back to the conversation on hospital safety and you know, hospital healthcare acquired infections and so forth. Yeah, obviously you can have things go wrong in seeking out healthcare, and so that's probably true. Not even just from the you know, beyond the financial side. There's several things in what you mentioned. The DEXA scan story is very funny to me, just because it's, I'm guessing.
So I have a lifetime of stories.
I'm sure. I'm guessing in the DEXA scan story, what they may or may not have mentioned is, as far as I understand it, there are some of those value-based plans that incentivize DEXA scans, because then it can help them foresee, you know, people who have risk factors in advance. So that may have been part of why that's the protocol, is we got to do this because then it's a value-based check mark, you know, or whatever. So, and there's a lot of check marks in value-based care, and some of them are great. I'm not a doctor either. Some of them make sense to me as a layperson, and some of them to me as a layperson, I'm like, I need a doctor to explain this one for me, because I don't get it. And I think that sort of empowering the layperson to know when to ask the question is really what I'm getting that you're trying to achieve, because that's always been sort of Oz behind the curtain. The decision making comes from 10 years in medical school and 20 years of practice, or it comes from a clinical protocol built into the electronic record, or we don't see it as the patient. We have no ability to see that. And I think if I'm understanding you right, you're trying to democratize that a little bit and spread that knowledge around. And that's great.
Yeah. And I think that, you know, to be transparent about all of this, you know, we're not trying to solve the complex stuff. So our market is not the Medicare market, right? I would love to go to the Medicare market. And in my book, you know, one of the things that I wanted to do was to be able to opt out of Medicare, and be able to have more control over, you know, the care that's accessed. But as I said earlier, and we all know this, the older you get, the more likely that things are going to go wrong. And at some point we're all going to die. So it's just how that happens. And I think that by doing chewable chunks, like addressing the small issues that aren't catastrophic, right? I'm not going to get in the way of someone who gets an ALS diagnosis, right? Like, you find a good doctor, and that, you know, that or MS. It's just there's these long, chronic, really serious, catastrophic issues. There's a place for that, and I don't think that's a digital health solution yet. But we are dealing with, you know, our market. A lot of it is orthopedics, right? Like we talked about the back. That's, you know, neurological also, but like any of these joint problems. So our market, like I said, not Medicare. So we are in the, like, you know, 30 to, it's an interesting situation, because the younger you are, you don't think anything's ever going to happen. Right. So, you know, you don't want to get on something that you may think KnowThyself is going to be like, oh, well, you're overweight, and, you know, here's all these things that are wrong with you, and you need to stop drinking, and, you know, your diet's ill. That's not what we're about. I don't care, right? I'm not rewarded if you get better. I don't care. You know, if you're not honest with us, you're not going to get a good answer. And, you know, we are trying to collect the information so we can give you useful tools for yourself. But we're also not trying to address super serious issues. What we are doing is saying, odds are, you know, if you know, your wife has a baby, you, husband, are probably going to gain weight. You know, just know that's happening. Just because of and it's not you shouldn't look at it as like, oh, this is how I'm going to be forever. My wife had a child. Like the house got topsy-turvy, like I wasn't getting a lot of sleep. I was distracted with work. I was stressed out. Like, that is totally normal. Right. And so we want to be telling people like that to me is a health outcome, right? Doctors don't care, but like, we want to be telling people these, like you got divorced. It's stressful. Like these things are going to happen. And if this year, you went on antidepressants, and it's been a year since then, you still need to stay on them. Right. Like, you come back and do Know Thyself year over year. And it's like, okay, so you're still on these meds. Like, you still have insomnia. It's not good to be on a lot of the medications for insomnia for a long period of time. They're not designed for that. So if you come back to us and say you're still on it over a year, we're going to say, you should talk to your doctor about that. We're not going to say get off them because that's dangerous and that's not our job. We don't diagnose that. But we're going to flag it for you and say, you should talk to someone about this. Yeah. And here's why, because it's dangerous.
Yeah. No, that sounds really cool and makes a lot of sense because again, I just keep coming back to that word. It's democratizing that knowledge. It's spreading it out to more people and giving it in an accessible way and helping to trigger some of those conversations. Right. What I'm wondering though is on a different end of the spectrum is in my opinion, some of the wasted care or unnecessary care in America comes from health insurance protocols, which is ironic because the protocols are to try to get people to not have unnecessary care, but they will, okay, your knee hurts, get an x-ray, then get, your CT, then. And I'm sure that I'm going to mess this up, but I'm sure if you went and talked to an orthopod, they're probably going to be like, look, just get a CT or just get an MRI. Just go straight to the most clearest picture and just get it done. And so because of an insurance protocol to go through more conservative testing first, you end up with more radiation and with more expense. And that's the irony to me of some of these protocols. Do you see Know Thyself helping in any way consumers to push back against that, or do the payers hold too many of the cards? Our raison d'etre is to do something about that, right? I mean, we're trying to get people to not do the things that they don't need and do the things that they should have, and understand, the gray area, and part of that decision-making process is understanding cost. So if you do go to an orthopod and your knee hurts, I've been a lifetime runner. I was a college athlete. That's, de facto going to happen to me. Right. I went in there and I knew, the guy was going to send me for an x-ray in the office because he's an orthopod. He's got one in there. And I also knew it wasn't expensive, right? It's just not like people don't understand the range of costs between a CAT scan and an x-ray. It's like order of magnitude. And then of course there's the inconvenience of going and getting the CT scan as opposed to like, just go over there and like, we'll get the x-ray done. So we want to be helping people not do the things that they don't need. I would say that a lot of doctors not only do these things because of the insurance protocols, or I think that for a doctor, a CAT scan, a CT scan is going to be a way better picture than an x-ray, right? And if they want to know, I think there's a lot of that. That's how doctors are built, right? They want to understand, they want to problem solve, they want to figure it out. Yep. Our view is we want to know what you're going to do about it, right? So we don't diagnose anything. We're saying you might get these things. Here's probably what's going to happen. We care about what happens once that diagnosis is made. We want you to understand what's going to be done about it. And that's a whole, like I said, I'm not a physician, and I show Know Thyself to my physician friends, and they're like, I don't get this. And it's like, it's not for you, right? It's for the
consumer. And a final point that I would add, you talked about the irony of insurance companies having these protocols to do all this stuff. Well, the whole point of that, and I think this is a big misunderstanding about, the Affordable Care Act and putting all of these, 10 essential benefits and forcing companies, insurers to cover all this stuff. And the insurers are like, God, it's going to make everything so expensive, that's ridiculous, and it was like, well, it's really good for the patients because then they'll be able to get all this stuff for free. Mm-hmm. Well, the more that you tell someone, i.e. the insurer, that they have to cover, the more expensive the care is going to get. So of course the insurance industry was like, oh yeah, sure. Back channeling. Yeah. Tell us to cover more stuff because then we're just going to turn around and charge you more.
Right.
And that's what's happened. And that is, so never look to the insurer. And even I wrote about it in my book. Never look to them to cap payment, right? They don't want to do that. They want you to access a lot of care because if you do, you just get charged more for it. And that's just an unfortunate situation that, so just avoid, if you can.
Well, insurance is risk pooling. So the bigger the risk of the population, the more costs the members are going to have to pay in. And in that case, it's the employers. And I think that has its own, 5 hours of conversation about the future of health insurance in America and it gets on being too political and so forth for this channel. But yeah, I mean, there's a lot of questions about that. I think we're all probably thinking about. I'm looking at the time, and I want to make sure that we're I'm respecting your time this morning. And one of the questions from a career journey standpoint, I did want to ask. So architecture, but now you're in healthcare data. How does that journey happen?
Circuitously. It was pretty logical to me. I actually went to college as an applied math major. I love math. I love data, hence I'm still in it. I loved problem solving. I'm still in it. But I liked design and I liked the human interaction and architecture is like the best major. I mean, I feel like everybody in America, everybody in general should just major in architecture because it is strategy, it's math, it's science, it's psychology, it's history, it's art, it's everything. And I look at it like that has prepared me to work in the healthcare industry because it's a holistic view of how all the puzzles fit together to design a building. You have to think about how people feel. It's not just, is it going to stand up? Like, why am I putting a wall over here? Why is the window there as opposed to there? Like, there's so much logic and thought that goes into good architecture. And that fuels my fascination with healthcare data. Why do I need this? Like, what is the simplest way to do something and get rid of the nonsense? What's the simplest, get to the source, the core problem? And when you're building a building, it's like, how am I going to make this thing stand up? Like, how does that happen? And you get rid of the nonsense. So, that's sort of jumping to where how those two things work together. But I realized when I interned, interestingly, for a hospital design company when I was in college, I thought it was so boring, and I talked to my coworkers and it was like, well, what do you do all day? And it's like, well, I draw ceiling tiles and toilets. And, I'm like, it's going to kill me. Right. And so much of the money in architecture, a lot of it is industrial. It's business projects and putting cubicles. It just, it didn't satisfy my need to do problem solving enough. And I think it's an industry that's very glorified in the media. It's always like the hero architect. Well, that's like, 0.5%. And architects, if they're lucky, will get one project in their career that has allowed them to have freedom. I mean, they're really like pent up artists, and it's just a fascinating field. So I realized that wasn't for me. And I applied to companies that had facilities after I graduated college. I almost went to work for Saks Fifth Avenue, doing like I'm like, where is property? And I grew up outside of New York City. So I wound up working for a bank. At the time, I worked for Manufacturers Hanover, which is now part of JP Morgan Chase. And they were it was the biggest banking merger in American history. And so it was a big facilities consolidation project. And my friends were bankers and they were going to business school. And my parents, my father was an organic chemistry professor. He went to Yale and Harvard, very educated. My mother was a nurse. And she was on the board of education. They value, and they're like, you have to get a master's degree. You have to get your degree in architecture, push, push, push. And I didn't want to just do that. So I got a degree in architecture and business. And I went to Michigan. I got a scholarship there. They had a joint program to do it. Washington University has one also in St. Louis, which is awesome. And a couple, we're seeing more of this joint degree and engineering and business is always a big one. And I think it's great because, you should never stop learning, and grad school shouldn't be so specialized. So this is a long answer, but ultimately I got picked up by Deloitte because they had a facilities planning merger practice in hospitals. Oh, okay. And my experience in the doing facilities mergers for a bank translated over. And in the 90s, when I started, mid-90s, a lot of the hospitals were merging. Mm-hmm. And so to be able to walk in and be like, you really can't add the ORs that you need in this layout. You should really, we should move this whole practice to the other hospital, or we should shut this down. So then it became this whole financial operations. Like I just got in every single department of a hospital and learned how all the pieces work together. And I love that. And so that's sort of, fast forward to where I am now.
Well, that's people's journeys are fascinating to me. And that's one of the things I try to focus on here on this podcast is just how people have gone through their career journeys, because some of them are very straight line and some of them, to use your word, are circuitous in their career. So I appreciate you sharing that with me. Is Know Thyself available now? Can people go get it now, meaning at the time this will air in January? Is it available? Can people go get it? Is it an app? Like, how do they find it? How do they get to Know Thyself?
Yeah, thanks for asking. So it is online. Our website is knowthyself.health. We are going to market with a preventive testing guide. So we had to figure out, what do consumers want? What can we offer for free so people understand? Because we are asking for a lot of personal information. We want people to understand, to get something out of it. We also have to target a specific group of people because we're a small company and we can't market to everyone because it's expensive. So we are targeting women. Like I said, they access the system more. So initially they're going to have more to gain from a tool like Know Thyself. But men can also do this preventive testing guide. So if you go to our website, there's an app tab, and it is a preventive testing guide. It's got like 17 steps. It takes a few minutes to do. And it will tell you if you need or might need 4 preventive tests for women and then 1 for men. So it's a DEXA scan is on there. There's a colonoscopy, the mammogram, and then a pap test. And it's, try it out. But that is the initial free offering that we have. And then when we get our funding, we are going to go to market targeting women who want to be pregnant or are pregnant to explain the protocols around what are needed for that. Because there's a lot of stuff. I said I had stories. I've had 2 kids. A lot of things tests that are done that are not necessary, but are just ordered. And then there are things that you really do need to do. And we want to be able to differentiate and, just give people the best care, help them help themselves.
Absolutely. Well, that's great. KnowThyself.health.
Yep.
Janis Powers, thank you for being with me and talking about your career journey, about healthcare data, about the monetization of that data, advocating for yourself, and a whole bunch more today. I really appreciate your time and have learned a little bit, and glad to be with you today.
Thank you so much.